So why might you need an assistance to deliver baby with an instrumental birth? Well, the common reasons for being advised to have an instrumental delivery would be that the midwife or the doctors have concerns that your baby isn't coping with this pushing phase of birth. Perhaps by listening into the heart rate, we've got concerns that your baby's not coping so well with this part. Typically, to monitor your baby's heart rate in birth, we would listen to the baby for 1 full minute following a contraction every 15 minutes up until the point that you're ready to actively birth your baby. At that point, we would likely listen in every 5 minutes. We use the sonic aid like we use to listen in to your baby on antenatal appointments. If the sonic aid monitoring suggested to us that baby's heart rate was dropping and taking some time to come up after the contraction, the midwife might then ask if we can use continuous monitoring, which is called CTG. 2 belts around your abdomen, 1 to monitor baby's heart rate, 1 to monitor contractions. And it could be that the CTG says that yes, this baby is struggling a little bit to cope with this process. And that if we just continue with your body's instinct to bear down and push, that baby might be another 30 to 60 minutes away from delivery, and that we have concerns your baby doesn't have the reserves to cope with that, so that we wish to expedite or bring the birth forward. It could also be that there's some medical reason to limit the amount of times or the amount of time that mum is pushing during this phase. Or another common reason is that despite mum's very best efforts of maintaining those UFO positions, being active and upright and, good contractions, that for the efforts she's putting into it, that for some reason baby's just not coming that last little bit. Maybe baby's not quite in the optimum position, and that's why they're just not coming down that last little bit. How do we decide whether to use a forceps or a ventouse? Well, the decision is based on a clinical assessment. So at the point the midwife suggests to you that, perhaps you may need a hand, she would go and discuss it with the doctor, and the doctor would come in and likely want to have a good feel of your bump and perform a vaginal examination. And this is giving us lots of information about the size of your baby, and the position that your baby's in, the amount of swelling on baby's head. If you've been pushing for a significant amount of time, what happens is the baby's skull bones just gently overlap, and this is nature's design to make your baby's head physically small to fit through. As that process happens and the skull bones overlap and your baby's trying to get into the smallest position to fit, your baby will get a little bit of soft tissue swelling on the scalp, and that is normal for all births. But if you've been pushing for quite a long time and baby hasn't been in the optimum position for birth, it could be that there's quite a lot of swelling at the back. If there's a lot of swelling, then sometimes it's not suitable to use the ventouse, and we may need to use the forceps. So it's not a parental choice at this point. It's the safest instrument to deliver your baby based on the clinician's assessment. The forceps and the ventouse might exacerbate that swelling or make it look a little bit more pronounced, but remember, it hasn't caused it. That swelling was there already. The ventouse that we commonly use at Harrogate is called a kiwi, and what happens is we do a vaginal examination and we find the right bit of the baby's head to attach this to. We then apply some vacuum here, which gives us some suction and something to ease on. Now, if you look at this is really helpful for understanding how close your baby is. If you imagine that this is on your baby's head and this is outside the vagina, you can see that actually your baby really isn't far away. It's just got that little bit of a curve at most to go. So that is how we would use the ventouse. Forceps are a little bit like giant salad servers, okay? You'll be able to see a picture of those on our slide. And what happens with the forceps is the doctor will apply them one at a time. So one is applied and sits here, then the other one is applied and sits here. and they just provide like a little cradle for the baby's skull to fit in. The thinner end of the forceps, the two sides lock together, and if they won't lock, we can't use them. So by locking together, the doctor is ensured that actually the forceps are just sitting like this around your baby's head. And what can't happen when they're locked is they can't physically push together. Okay, so it's actually protecting your baby's skull, your baby's head there. Using forceps or ventouses, you would still need to follow your body's urge to bear down. So if your body is really telling me I want to push, then keep going with that, okay? But what we're going to do is, as baby's making that gentle transition round, the instrument is going to stop the little slips back in between and is going to give a gentle downward traction to help guide baby as well. So people's envisage of what forceps might be like. I always relate it to the childhood story of the enormous turnip, where the farmer was trying to pull a turnip out of the ground and it wasn't coming. So the farmer's wife pulled the farmer, and the son and the daughter pulled the farmer's wife, and we had this big long line of people all pulling. Well, that's not what instrumental birth is. It's that gentle downwards traction, stopping a bit of a slip back. We aim to deliver your baby in 3 contractions. So as you get your contraction and you're getting that urge to push down, then we'll be guiding baby along. If after 1 to 2 contractions, we're just not really feeling any movement and baby isn't moving as easy as we expected, then we might say at that point, we don't think this is going to work. Now the means of delivering your baby is by an unplanned cesarean section. But using forceps or ventouses, we would aim to deliver the baby within 3 contractions. These are never going to be preferences. I've never seen a birth plan yet that says, oh, I really hope that I have forceps. Nobody wants forceps, but it's just a fact that actually in Harrogate, in Yorkshire, in the UK and worldwide, that not every baby is born vaginally with no assistance. And sometimes being able to give baby a hand out can be a life-saving thing. So it's never going to be as far as being a preference, and hopefully you won't encounter these on your baby's journey of birth, but hopefully understanding a little bit about them can help you feel more empowered and less anxious if you do.